Hello everyone, this is Randy Clough from MCOL, and I would like to welcome you to our webinar event today, the Delaware Valley ACO, Key Lessons Learned in Our First 2 Years. Our speakers today are Dr. Katherine Schneider, President and CEO of Delaware Valley ACO, and Joel Port, COO, also with Delaware Valley ACO. Before we begin, we do have a few housekeeping items to cover. If for any reason you experience technical difficulties with the web portion of today's presentation, please print off the PDF version of the presentation that was included with your dial-in instructions. The link is www.healthwebsummit.com/ACO052516.pdf. Our speakers will be taking questions today using a live chat feature. So now and at any time throughout today's webinar, you are welcome to submit your questions. As always, if you require any other assistance, please contact the Healthcare Web Summit office at 209-577-4888. We are now ready for our speakers to begin.
Thank you. We're very happy to be here and speaking with you. I looked at the registration list. I know we've got a couple of old friends on there, so nice to see you all virtually, and I hope that you enjoy it. So I'm Dr. Katherine Schneider. I'm President and CEO of the Delaware Valley ACO, and I'm here with Joel Port, who is our Chief Operating Officer. He was employee number 1, and I was employee number 4 about a year and a half ago. We've now grown up to about 35 staff on our direct team. Joel and I are actually going to, go back one. Joel and I are actually going to be handing off back and forth a little bit to keep it lively, and we will keep an eye on your questions, but unless it's a clarifying question, I think we're going to hold off until the end of our remarks to really get into more of a discussion. So our other title for this presentation is really the Wild Kingdom of ACOs and some of our lessons learned. So, you know, we've got the zebra picture up here because some of you may remember that a couple of years ago, all of the pundits and futurists in healthcare were out talking about ACOs as a unicorn, that no one had ever actually seen one. They were a mythical creature, and that they probably didn't actually exist. Then I think they ate their words on that, and fast forward another year or two, and folks were saying that ACOs are zebras and that they do exist, but they're very rare animals and they're only to be found in zoos. And I'm here to tell you that, in fact, if you know where to look, zebras are not a rare animal at all. They are not an endangered species even. They are very abundant, and what's interesting is that they're all different. So the zebra stripes are like a human fingerprint, and I think that metaphor actually is very relevant to accountable care organizations because there are several hundred ACOs in the country now, about 400 and something in the Medicare program specifically, and another couple hundred that are doing commercial ACO work. So we're no longer a unicorn and we are no longer a rare creature, but we all are very different. And so we're here to talk about lessons learned. Gina, go ahead. Over our couple of years of existence, and it'll be really interesting to see if it resonates with you. So here is a little word cloud that we put together last year by asking all of our board members and governance committee members to give us a couple sentences on how can we really add value in healthcare. And if you're familiar with these tools, the larger the word, the more times it appeared in people's responses. And so this really shows the population health view of the world. There's nothing in here that talks about typical hospital bricks and mortar or operating rooms or, the typical numbers of kinds of metrics of values that we think about, those of us coming from the health delivery world, but really focuses on population health. So moving on, I just have to get one thing clear, and that is that first and foremost, the Delaware Valley ACO is not in Delaware. We can see Delaware from here. We have staff that lives in Delaware. We probably have some patients that live in Delaware, but we are actually based in the greater Philadelphia region, which if you're from Philadelphia, you know that is what's referred to as the Delaware Valley. But we cover the greater 5-county Philadelphia region, plus we have some physicians and patients across the river in New Jersey, so it's really the Philadelphia region. I'm going to turn it over to Joel to talk a little bit about what we are, who we are, and how we got to be who we are.
So hi everyone, this is Joel Port. Good afternoon. So the slide you're looking at now, what we're trying to explain is that we're not simple. This is a complex structure. Some days I wake up and I wish we were just a single physician practice that qualifies for MSSP, but we're a long way from that. So we actually have 4 very strong regional members with Jefferson, that's an academic medical center, Mainline Health, which is a suburban health system, and then Doylestown Health and Holy Redeemer, which are strong community hospitals with a number of supporting services in their own community. And when we first started out in 2013, our goal was just to have enough Medicare beneficiaries, which is 5,000, to have their application accepted by CMS. And we actually started the first year with over 30,000. The initial members at that time was Mainline Health, Jefferson, and Holy Redeemer. They also brought in some of their employee groups, but we also have a number of independent groups. In fact, it's been pretty consistent starting back in the first year of operation of 2014 through 2016, that about half of our physicians are independent practices, which we feel really good about. This marketplace of physicians is taking our Medicare Shared Savings Program very seriously, as well as focusing on what the future is for themselves and for the ACO in terms of health care. And supporting each of our health system members, they each have a clinically integrated network that either was actually operational back in 2014 or still under development. And then in 2015, Doylestown joined us. They also brought in a number of independent physicians. And we'll get into some more facts later. But today, we have over 100,000 lives in the Medicare Shared Savings Program, supported with over 650 primary care physicians.
So the value proposition here, as you can see from that sort of European Union view of the world on the previous slide, there is infrastructure being built locally as well as centrally. And so one of our lessons learned here is talking about our value proposition as a super ACO or a super clinically integrated network, which is regional and is composed of what we call pods, those more local infrastructures. We have a lot of dialogue around what is central, what should be decentralized, and how can we add value together, going back to that word cloud. So our value proposition is that we serve our member organizations and physicians as a convener and an accelerator, and really giving everyone in that a foundation to move from volume to population health as a business model. Through the DVACO, we are delivering to our region a world-class care model that's differentiating beyond the sum of its parts. And the word care there and the C are highlighted in green because it's a reminder that this is all about the care model. I'm a physician. A physician was deliberately picked to lead this entity because our firm belief is that if the care model doesn't change, then we will not accomplish anything different. So you cannot achieve success in an ACO by just adding new contracts, adding new committees. You actually have to change the way care is delivered at out in the community, whether that's the bedside or the primary care office or other. So we talk a lot about the care model and changing the care model. So one of my lessons in having done this kind of work for my whole career is that this is actually around the third iteration of an ACO that I have led, starting back to the physician group practice demonstration program at at another health system in Connecticut, and I know we've got one former colleague from that on the webinar today as well. So, you know, this concept has been around for a while, but it's really the first time now that it is clear in everyone's mind that this is sticking. So I don't get questions anymore on, you know, sticking the head in the sand, or physicians just saying, you know, this is some pilot project, or it's all going to go away when, you know, the Supreme Court, whatever, or the next election or whatnot. So it is really clear that the train has left the station, and, you know, if we want to start talking a little bit about MACRA and those kind of things, you know, the horse has not just left the barn, but the horse is in the next state. And I think that the traction we've gotten here in this community, especially with physicians, is that they get that now. They get that this model is not going away. Now, that's not to say that everyone has bought into it completely. So there are some physicians in our community who have really opted out of being able to move towards this future. They're planning to retire within a few years, or this is just not something that they can make the kind of necessary changes to adopt. And that, in our region, that even includes down to the point of still not having an electronic medical record. And that was an absolute bare bones prerequisite for us, a requirement 3 years ago when we started, and we've added requirements since then. So, but you know, most of the physicians and in our community, and certainly our health system owners, are invested, and they just need help to get there. So, you know, as a clinician, it's almost like working with someone on any kind of behavior change. Is you're always going to have the pre-contemplators, and, you know, you try to get them to contemplate, but those who are contemplating or who are ready to change, you give them the help that they need to get to the next stage of change. And so that's how we really are viewing the work that we do with our health delivery systems. So, you know, why do it? Why be the first in the region to really be doing this at scale? Well, the view is better from ahead than it is from behind. And, you know, certainly there are advantages to being the early adopter in the market. It takes time to build these infrastructures. It takes time to, you know, to get some success under your belt. And so, you know, that's why our member health systems were really the first to jump in here in a large scale within the Philadelphia region.
So here's just some fast facts for us. So we are a joint venture, as previously mentioned, supported by 4 strong health systems. It's set up as a for-profit limited liability company. We're seen as one of the largest ACOs in the country, and we're very fortunate in 2014, our first performance year, to actually achieve shared savings. We finished up in, if anybody's counting, in the top 10 of ACOs. Today we have over 100,000 lives, supported by 650 primary care physicians. And as Katherine mentioned, all these physicians have access and use an EMR. In fact, what we're working with all the practices now, if they haven't already achieved patient-centered medical home recognition, we have coaches that are working with them to advance them up to that goal. In addition to Medicare shared savings, we also have some commercial partnerships. These are all upside shared savings programs at this point with Aetna, Humana, and United. Also, we started working back in 2014 with our employee benefit groups, and we have a tiered product today. And the primary tier, which is the most beneficial tier to the employees and dependents, is made up of the Delaware Valley ACO primary care providers. And then along with that is our specialist strategy. So we went into the MSSP initially as an ACO saying we're just going to focus on primary care physicians. We do have some specialists today through some of our multi-specialty groups, employed as well as independent large groups. But we really don't feel we have a well-thought-out planned specialist strategy, and that's really for the next phase of development now that our primary care base is stable and developing.
So as Joel said, we did have success in the Medicare MSSP program in 2014, and within our cohort, that put us in the minority. Certainly only 19% of 2014 starters earned any shared savings in their first year. And as Joel mentioned, our savings payout was substantial, putting us in the top I think, 9th largest payout in the country at $6.5 million to us based on a shared savings, on a total savings to CMS of $13 million in our first year. So everyone wants to know, how did we do it? And, I'll always be the first to say it helps to be in the right place at the right time with the right people on board. So, when the ACO was started, our member health systems and physicians were really, had self-selected into this because they were already working on things that were going to start to move to the dial. And so not surprisingly, we did see a substantial reduction in hospital inpatient expense in the first year, and actually facility outpatient went up a little bit, as you would expect. So, what was interesting, so first when I looked at this data, I thought, okay, we just moved a bunch of admissions to OB status, and that's where we got a delta and were able to save money. But what was interesting is that once you keep particularly a frail elderly person out of a hospital bed for 3 days, the next thing that happens is that skilled nursing facility goes down, home health goes down, DME goes down, ambulance goes down. And so actually we saw savings really across a wide spectrum of the continuum. The only thing in Philadelphia that we underutilize is primary care. And so, we're really trying to work with our primary care docs, and we'll talk about that, again, changing the care model. But there's just so much opportunity for us. So of that $6.5 million in year one, we retain 30%. 30% go back to our owner health systems, and 40% went to the primary care physicians who were participating. And that represented a substantial, you can do the math yourself, but there were 250 PCPs that were participating more or less in 2014. And so that translates to, on average, a pretty sizable check. And for some of the PCPs with large Medicare panels, and particularly with those who were very disciplined about seeing their patients at least on an annual basis, it translated into a really substantial check, and certainly more than enough to get people's attention and to understand that there's real opportunity here. So there's still plenty of opportunity. One of our challenges is just as we have grown exponentially in size year over year, it's almost like starting from scratch with a new ACO, with new baseline targets, with new practices, with a whole new patient population. So that's the downside of the good news of growing fast is that you're really almost starting over every year. So, we've done a lot of deep dives into the weeds of what it takes to succeed in the MSSP. And for us in particular, this whole issue of the attribution model. And if you're not familiar with the Medicare Shared Savings Program, and we're not going to get into how it works, we assume most of you know how it works, at least at a high level, but this issue of knowing who to assign the patient to is not straightforward, particularly when you're not a single tax ID physician group that can just kind of go into your EMR and when CMS attributes to the ACO, it's equivalent to attributing to the TIN when you're just one group. And then you can just go in and kind of run it compared to your EMR PCP assignment list or something like that. So, most ACOs are more than one group or one TIN, and then have to start sorting out some of these issues around attribution. So I thought it was worth our getting a little bit into the weeds on this because there have been some very, very important lessons that we've learned through, Joel and me and our team of analysts. Actually, for a while, we had weekly meetings that we would call the Attribution Fest, where we would just dig deep into this data and try to understand what was really going on, because there was some weird stuff going on that we had to try to figure out, particularly because we had money to distribute in the first year. So it was even more important to know, how many patients were on your panel and who were they. So I'm going to hand it over to Joel to talk a little bit about some of this detail for a few minutes, and then we'll take it back up to a higher level.
Thanks, Katherine. And just to add a couple other general comments on our first real weedy topic, is that the other value of attribution, aside it was part of our result sharing formula, it's also important to identify whose patients are these, for whether it's a care coordination, quality reporting, and our physicians are asking for a list. And as long as we're going to have programs such as Medicare fee-for-service or traditional Medicare where people have choice versus an HMO product, we're always going to be focused on very much on attribution. So just a couple of things I just want to mention that these were just some lessons learned as we got into this. So I mentioned today we have over 650 primary care physicians, and in our first year we also had a significant number, but we also had a number of nurse practitioners and PAs, and it's always made up about around 20% of our provider workforce. And but interestingly, up until 16, there was no attribution to nurse practitioners or PAs, and we had a number of unidentified patients in our database that didn't sync up with our practices because all they ever saw was a nurse practitioner after the first attribution was made. So we had to actually literally do some manual work, and we've set it up today. We actually use Salesforce to keep track of all our information and identify all our providers, and that's been helpful to us because there's, with about 20% of our providers being non-physician, it really changes our attribution when we count them. Also, we saw that we had a number of hospitalists that were getting attribution. And the way, if you're familiar with the CMS attribution formula, if you're designated as a primary care physician, which is pretty much limited to family practice, internists, GPs, and geriatric specialists, most hospitals, or at least in our neck of the woods, a lot of our hospitals are either internists or family physicians. There's no hospitalist designation as a specialist in the CMS PICO system. So we just made a decision. We figured all these patients really should be associated with PCP, but when attribution is made, it's really done if there are primaries, if there are more than one primary that's getting attribution, it's typically based on the frequency. So if someone is hospitalized, they're going to have a number of hospitalist visits, so we needed to do some reallocation to that effect. Another area we learned is that frequently a number of our, in our larger multi-specialty groups, we were seeing attribution not only to the PCP, but also to the specialist. And it became a larger problem with medical subspecialists. And as you probably know, to become a cardiologist or a gastroenterologist or rheumatologist, you first go through an internal medicine residency. And what we found with a number of these physicians is that when they were first registered in the Medicare PICO system, they were registered first as an internist or internal medicine specialist. And what PICO's literally, or what CMS does to assign attribution, they go to the first specialty number in the PICO system. So we just went to all our medical subspecialists, and actually today we actually can check on their status. But if there's a cardiologist, and if their first specialty line wasn't indicated as a cardiologist, but actually as an internist, we actually worked with them to switch that designation. So we just feel PCP attribution is critical for us, and we want to really minimize that attribution to specialists, which would throw it off. And then what we were most proud of at the end of 2014, that we actually had to attribute 33,000 Medicare beneficiaries to all our number of TINs, and there were actually about 35 TINs at the time. Today we have over 100. At the end of the day, it was really, there were only about 130 patients that we actually manually had to go into and figure out who saw that physician last, or where did the patient go for an annual wellness visit or data visit, and we were able to sort it out. And we worked with the physician advisory group, and we shared a methodology with them, and they all blessed it. And in fact, we also brought in an auditing firm to check our math and review our methodology, and that also gave us a lot of credibility in this review. So just a couple other things in terms of redefining attribution to keep in mind. there's a lot of information out there in terms of attribution methodologies, and what you may want to think about is having more than one attribution methodology. Just keep in mind what is the goal. Is the goal for result sharing? Is it for care coordination? Is it just to assign patients? And with Medicare shared savings, which is a little different than Medicare Advantage, obviously. A lot of programs out there, if it's based on attribution based on a Medicare Advantage program, they typically use NPIs, or the physician identifier. We just find assignment to the tax ID number makes more sense with MSSP, at least for us. And we've worked with our analytical tools to actually design that and support attribution to TIN. And maintaining that type of hierarchy is helpful. The other thing what we found over time, and we didn't appreciate it when we first got into this, is that the providers change employment quite frequently. And Salesforce, at least for us, has been, or any database that you use, I'm not here to advertise Salesforce, but any database that you use, it's very helpful if you can keep it up to date, because just maintaining that information will help you take in when you're looking at claims data or doing any other analyses. It's very helpful to keep that database up to date at all times. And then the other just thing to keep in mind is how CMS uses PCOS and the two-digit specialty codes, and to keep them up to date and actually work with your providers to make sure their information is up to date. And in fact, in the new provider agreements that CMS is requiring starting for the 2017 MSSP year, there actually is a clause CMS asked us to put in all the provider agreements to actually require our participating practices to keep their PCOS information up to date, and it's now part of the agreement. Katherine?
Okay, thanks, Joel. I mean, there's a lot of detail in there, but this is the kind of detail that really matters, because we really found that we could not sweep these issues under the rug or tolerate any really error in there, because when you're trying to either, get to the point of care and change behavior, if you don't have it right with who's the doc, you can't get anywhere. And certainly if you're distributing funds, it really has to be accurate. So really, everything has been built on this foundation of getting attribution right, and it's really underappreciated. We've had vendors tell us, CMS does the attribution for you, so there should be nothing to do. But there really is a lack of appreciation that CMS only gets it to the ACO level, and then they don't care. You got to figure it out, and you need claims data to figure it out. You can't figure it out easily otherwise. So, thanks. So I want to talk a little bit. Turn back up to like 10,000 feet and talk a little bit about the care model and what we've been doing here. So, as we both mentioned, we are very focused on primary care and changing the primary care model in the greater Philadelphia region. When I started here, I was actually surprised at how far behind we were from some other regions. We think, we're very proud of being a very advanced med ed city and region with all kinds of very high-end quaternary care capabilities within a very concentrated square mileage. But, primary care has really been a bit neglected here and fragmented. And so even among the self-selected group, when we started the ACO, where you had to have an EMR to come in, fewer than a quarter of our practices were designated NCQA PCMH recognized when we started. And that was despite this market having substantial incentives from the commercial payers like Blue Cross and Aetna. There were pretty good incentives for being PCMH recognized, and the practices were leaving that money on the table, tens of thousands of dollars per doc in our estimation for many practices. So we did decide to focus on the PCMH model. It's not perfect. You can always just kind of go through the motions of check a box type stuff with any of these kind of programs, but we felt that there was already market recognition, and it did give a good standardized template to follow. So we have a whole practice-facing team here at DVACO of practice transformation coaches that go out and work with the primary care practices primarily the smaller independent ones. The large employed groups tend to have their own internal resources. But we're helping these practices to achieve PCMH recognition, which has now become a requirement for participation in the DVACO going forward. And even those that are already recognized are finding that having a trusted partner around practice management in general is highly valuable. So we have a solo practitioner, for example, who has now asked, even though he's been recognized PCMH for level 3 for a year already, we helped him get there, he's asked to meet monthly with our team so that he can have backup for his own practice management team, which is small and very isolated and needs that outside help and validation for doing all kinds of things around improving efficiency, optimizing their EMR, capturing meaningful use appropriately, even learning the new billing codes like chronic care management and transitions of care. And those, again, are the kinds of services that we want to promote utilization of, because we think that's a win-win. It's a direct revenue win for the practice, but it's also care that helps to drive better population health outcomes. So this transformation team working with primary care has really been very important foundation for us. There's a lot of activity happening at our regional pod levels as well. And just to give an example of, Jefferson Health, which again, you think of that as a urban academic medical center, but Jefferson's really pushing the envelope around innovation and doing some things that would not be typically viewed as in their self-interest in the old model of volume and fee-for-service, such as opening the region's first 24/7 urgent care center, staffed all by board-certified ED physicians, one block from their mothership's ED. So that's a little bit radical for this region. They're also implementing a telemedicine service, and that's actually primarily staffed by those ED physicians in that 24/7 urgent care center. So, those are some of the examples of how the care model is changing. I'm going to get into a little bit more around how we're working with informatics, but we're focusing on complex and transitioning patients. The post-acute continuum is critical. We found the cost of care, total cost of care, we're substantially over average in the greater Philadelphia region, but on the post-acute side, in our first year, I think our skilled nursing facility spend was 70% higher than national average. And that's just not acceptable for quality of care, let alone cost of care. So, we're looking at care gaps and alerts, but I'm always a little bit hesitant on some of the metrics that are used to look at population health, because care gaps are not population health metrics. We're really, that's around process and around chronic conditions, but it's not a good population health measure. So, again, part of our goal here, obviously we'd like to make money in shared savings, but we are really trying to help our providers learn new skills for success in a value-based model, engaging patients in their care, again, especially primary care, getting them back to primary care when they've sort of wandered or gotten lost in the system, teaching our physicians about appropriately capturing severity of illness, and, we're always about caring and not about coding. The C is for care, not code, but nonetheless, an important skill in the future of value-based payment mechanism is proper risk adjustment and properly capturing severity of illness. And that's something that, again, has just not, maybe where you're from, that's been a standard out there for a while, and working with high Medicare Advantage penetrance, that's not been the case in this community. So, again, specialist care models, obviously critically important, and that is really our next iteration now, is to start to look at how do we engage specialists, and different specialists in different ways, most likely, going forward. So I'd mentioned a little bit about metrics, and again, the A in the ACO is around what we're held accountable to. Now the triple aim is, it's no longer lower cost, it's smarter spending is the correct way, the politically correct way to refer to that part of the triple aim. But what's really important is that, we're not focused on unit price. And I often have to sit with our hospital-centric folks and just remind them repeatedly that when we talk at the ACO about cost, it is the big bundle. It is the total cost of care across all sites, all services, across the entire 12-month period. And even if the patient is getting a service in California, but they're still attributable to us in the DVACO, that's still costs that we care about and that we should be trying to, capture and manage. And because of our size and the urban nature and just the nature of the attribution model, we have data on Medicare beneficiaries that at some point were assignable to us or attributable to one of our docs, but those patients are now spread out across 51 U.S. states and territories. So obviously some of them may fall off our attribution, but we're still looking, population-wide, no matter where the person is, that's what we're accountable for. So care gaps, more provider-centric. I hate readmissions as a metric because that is not a good population metric. We should be looking at avoidable hospitalizations. Who cares if it is a 30-day readmission or a 31-day readmission? If it's an avoidable admission at all, even an index admission, we should care about that. And some people are just truly really sick and probably need to be receiving a lot of hospital-based services. So, I worry about excessive focus on readmissions from an ACO perspective. I really firmly believe we should be looking at total avoidable hospitalizations, and there are good metrics for that. There's a lot that we are starting to learn some lessons on as all of these different models bump into each other. So, with bundles now really becoming very prominent, and for example, the new CPC Plus that CMMI is going to be rolling out, there's all kinds of this experimenting around, smaller bundles, larger bundles, primary care-centric bundles versus ACOs, and where they collide and patients are actually eligible to be in both potentially, there's a lot of confusion. So, I'm just seeing there's one interesting question that just came up, and I'll read it out loud. Is support for telehealth to facilitate shared decision-making with eligible patients and affiliated practices, for example, lung cancer screening, something that will be explored in the future? I probably can't answer that directly except to say that the whole issue of telehealth improving access to specialty care in general is something that is actively happening already at Jefferson. We really haven't capitalized as much as we would like to so far on telehealth. And when we say telehealth, it's really more of a direct-to-consumer model that we're looking at as a kind of part of the urgent care spectrum, more so than feeding into primary care or chronic care. But that's a good question. So keep going. This is the big issue that we always have to think of when I'm talking about 30% waste in the system, that is somebody else's lunch basically, and that as we start to get waste out of the system or non-value add care, that there will be winners and losers for sure. And particularly in a very bed-heavy and specialist-heavy environment, that will be the case, and that is one of the challenges. That is the elephant in the room, and sometimes we don't talk about it, and we all walk out thinking, how are we ever going to get this done? One thing that I have found very helpful in talking to particularly clinicians, to hospital administrators who are very proud of their progress in hospital safety and quality, is that when we talk about overutilization, as we learned from our first year in the MSSP, when you put someone in a hospital bed unnecessarily, that is a safety problem. Even if you have an incident-free hospital stay and do everything right, and there's no drug errors, and there's no noise in the hallways, and the food and parking are good, and all of that, you do harm to people by doing things that they either don't need or don't want done to them. And so trying to reframe this issue of overutilization as not just a money issue but a safety issue has really been a very helpful way to address it. So, many of you, I'm sure, have seen this sort of spectrum, and I know you can't read the slide, but this comes from the white paper on the alternative payment model framework out of the Learning Action Network. This came out a few months ago, and really it's just to remind everyone that this is a spectrum all the way from starting on the left, Category 1 fee for service, all the way through to global payment on the far side of Category 4, and that the upside ACOs are in Category 3A. Obviously there are a lot of questions around MACRA and where are we going to fit in terms of, it's not looking like a upside only ACO will end up qualifying as an alternative payment model or an advanced alternative payment model, but it's got to get more credit than just being moved back into Category 2. So these are really important questions for us because we're not ready for downside risk in this community. We already feel like we take a lot of risk. Risk comes in many, many forms for us. And when we think about risk, we've got operational risk, like just the fact that we are handling large quantities of PHI information over electronic means, using a lot of vendors that are in the cloud, et cetera, concerns about cybersecurity. That's one example of operational risk. Obviously, the investment risk, our owners over 4 years, including next year, will have invested over $20 million in the infrastructure. And, even though we made money in year one, much of that was redistributed back out to providers. And so, even under a shared savings model, there's almost a guarantee that you're not going to get that back in at least the early innings of this game of moving towards, not game, but the early innings of moving towards a value-based payment system. Just our existence has created some upset in the market, and I'll leave it at that. But, as we've provided an alternative to merger and acquisition, both between health systems and between health systems and their physicians, and provided, an alternative contracting entity within the region. That's presented some interesting dynamics. But, when we start thinking about financial risk, what should an ACO, what should providers be at risk for? We should not be at risk for pricing decisions that are out of our control, whether that's drug pricing or pricing of services that are not part of our network. I think we should be at risk for pricing within our network. There's the insurance risk issue, which is if you get big enough, you can overcome that. But, risk adjustment is certainly not a perfect science and cannot account down to the penny for the my patients are sicker issue, particularly as the information isn't captured very accurately yet. And, the thing that we, again, should be at risk for is our own clinical performance. So, again, an avoidable admission because someone didn't have access to primary care, that's the kind of thing that we should be at risk for. For a diabetic person that's poorly managed, and again, I get a lot of questions from physicians around, compliance and my patient's not compliant, et cetera. But, this is where the art of medicine comes in. And when we make it difficult for patients to be compliant, and if they have to take off a week's worth of work and be shuttled around to, various appointments, and it's very difficult to access the system and navigate it. I come from an IT background and say, the healthcare system has the worst user interface of any system out there. It's very hard for patients, especially the sick ones, to be compliant. So we should be at risk for making them able to be compliant. So again, the C is for care. We've touched on a couple of these points already. The incentives alone are insufficient to drive change, and that is why we are really out there deeply embedded with our practices and with our delivery systems working on alternative models. We can see that they've been leaving money on the table even under, P for P type of incentives. We can be incrementalist around change or transformational, and that's a whole other talk, but think about, for example, improving diabetes eye care by sending out some forms to be returned by optometrists and ophthalmologists so that you can track screening better and increase your screening rates. And I've done all that kind of stuff, so I'm not criticizing it, but that's incrementalist. What's transformational is having an app on the iPhone that when you're in any PCP's office or in any physician's office across the system, someone who's overdue for eye care can have a picture taken easily. And I mean, this is only slightly futuristic, but that's the kind of thing that's disruptive. And then finally, talking about variation, not all variation is bad. So variation in care when it's between providers is probably not a good thing. So if I, Katherine Schneider, with exactly the same symptoms, walk into 3 different provider sites and get 3 different plans of care when there's good evidence to support a best practice, that's probably bad variation. On the other hand, if 3 different patients that we all have the same symptoms, but we all have very different lifestyles, somebody works at night, somebody takes care of their kids, somebody maybe drives as part of their job, those are all probably things that should have a different plan of care. So patient-centered variation is a good thing. Provider-centric variation is not, and that's as we become more and more patient-centric, looking at individual risk, et cetera. Personalized medicine is one example of that, but we're going to be moving much more into those kind of things, and it makes quality measurement a little bit challenging at times. Okay, next. I'm going to move very quickly here just to point out that that's my dog wearing my Google Glass, which is the only good use I've found for the thing. I'm just trying to prove that I'm not anti-technology. I came out of informatics world. I believe in technology. Lots of times we use technology, it feels like we're just, dragging the EMR along by the horse, but we are really trying to get to the point where we can turn information into something actionable, and it does not always require fancy technology to do that. So our EMR and IT environment is very complicated, and this is just to prove that it's very complicated. We have multiple health systems, we have multiple providers with EMRs that don't talk to each other, inpatient versus outpatient, 45 different EMRs used in different practice environments. People are changing EMRs as we speak, so there are 2 large-scale Epic implementations going on. So this is not as simple as just kind of plug in interoperability and we're going to fix it all. So we had to have a pop health IT strategy that really recognized this very complex, rapidly evolving ecosystem that we live in. We're not the quick fix for the interoperability problems that have taken 25 years to get in place. The underlying workflows and tools have to be configured to support this change to fee-for-value from fee-for-service. So it's not only around population health tools and systems. And we really took a speed-to-value approach here. We could not wait for a multi-year implementation of connecting everyone to everything before we could do anything with information. So we focused on what I call, boring small data, as opposed to cool big data. So something as simple as just tell me where my patient is real time is a very small piece of data that we can get a lot of value out of, and I'll show you in a second what we did with that. So we have focused on analytics that do risk stratification, risk-adjusted costs, and care gaps, and also care coordination workflow. But again, focusing on what can we actually get to the point of care to make a difference as quickly as possible. And here's just an example of this was something that we were able to stand up very quickly. That is basically an event notification system. We tapped into our regional HIE, which was lucky for us, the timing was right. It was just getting its legs under it last year and connecting all of the hospitals in the region. And then we used a vendor called Patient Ping to bring in data from the post-acute side. So I think this slide may already be a little bit out of date, but essentially we are currently getting real-time notification when any of our patients walk through the front or back door of an ED inpatient setting, skilled nursing facility or home health agency in the region. And we don't have 100% of everything participating, but we've got enough of the big players that we're really getting, you know, thousands of notifications to help manage those transitions of care. So finally, you know, the O in ACO is for organization, and I'll just go back to it being about the C. It's about the care model. The organizations involved have to really be committed. As a side project, it absolutely will not succeed. It's barely worth doing if you're not going to really be investing in changing the care model. And, you know, there's a lot out there in the literature, and this is very early innings for population health and ACOs still. So, you know, trying to figure out who can do it better, hospital-based, doctor-based, big, small, high-cost, low-cost, urban, rural, et cetera, I think that is far less important than actually looking at what are people doing, how are they doing it, why are they doing it within different markets. Changing population health sustainably is going to be very hard to do in any silo, so we really all have to work together on this. And it goes back to what is the mission of many of our not-for-profit health systems, which is to improve the health of the community. And it's the first time in, you know, 100+ years that they've had a business model that can actually support that mission. So we get asked all the time about where's the ROI, and, you know, this is a long game that we're in. It's not just about the Medicare Shared Savings Program. So as Joel mentioned, you know, we've now doubled in size. We have 100,000 MSSP lives and now have just kicked off another 100,000 or so commercial lives because the more critical mass we can get in, the better. There's clearly strategic benefit, you know, with MACRA coming, which is, you know, clearly all the work we've been doing around accountable care is directly applicable to whichever route that MACRA goes in terms of Medicare payment. And, you know, shared savings are great, and obviously we want to get those, but there are other revenue streams that can support this transformation up front as we go. And so we've been very diligent about trying to find those revenue streams as well. So I'm going to stop there, and I know we do have a couple of questions that have come in. So there are a couple of questions that deal with reducing utilization and how do we address that in terms to the fixed costs of provider, staff, physical plant, debt service. Is reduced utilization matched by provider rationalization? And a similar question, you know, around workforce reduction, workforce redundancies, et cetera. Joel, do you want to take a crack at that one?
Sure. I do want to just add one other comment before I answer the question. In terms of the ROI, one thing I think we've learned, while there may not be an immediate ROI to our health system investors, there has been a very clear ROI to our participating primary care practices. And they were fortunate to get shared savings, but also our quality reporting every year helps them with PQRS. It's going to help them with MACRA and MIPS, and for these, especially for these independent practices, but the employee as well has benefited from it. So you've asked a very tough question because, you know, we have a very, you know, when you look at a hospital system, it's a fixed cost place. But I think if you ask our partners, the way they, you know, rationalize their investment in the ACO and the way they deal with the fixed cost, they just know the future needs to change, and they need to, you know, we all live in these communities with private businesses who are very concerned about the rising healthcare costs, and you know, the more we can focus on the system and make it more efficient, but it is a sense of almost competing interests when a health system invests in an ACO, but they've also made investments in their infrastructure on volume, not so much value. But at least speaking for our partners, they know that they need to bring more value into the community. As Katherine mentioned, it really does meet their original mission, which is to provide value and to the community and impact the community in a positive way. So there's no easy answer for this. You know, It's just, I think for health systems at some point they just have to say what is the future and how do we prepare ourselves for the future, which at least our members are very focused on that.
Yeah, and there are a lot of, this is not just a snapshot in time. So like we hear a lot about the physician workforce shortage and it's going to be a big catastrophe and so forth. So there's a lot of demand with the baby boomers aging, et cetera, that's about to flood into the system. So to some degree, it's, there will be backfill of volume just from the demographic changes in the community. And, we're going to have with, the Affordable Care Act, and again, just more volume coming into the health system, we have to have better ways of providing primary care at scale. And all of these team-based care kind of initiatives. So, there will be some right-sizing that goes on within a community-wide. There's no question about that. But again, do you want to be the commodity in that equation, or do you want to be, leading it and figuring it out? So I think we have time for one. There are a bunch of questions here, so I apologize if we don't get to all of your questions, but there's one question around the implication of not qualifying as an APM under MACRA. So I'll probably qualify that question to say that we are an APM, we're just not a, quote, advanced APM. And so under the proposed rules, that there is an extensive definition around who qualifies as an advanced alternative payment model, and that includes very substantial downside risk that's required, and also volumes of services and a bunch of other qualifying definitions. But to get to the questioner's intent, we still hold out some hope that we will qualify as an advanced APM. So those rules are not final, and CMS has been hearing loud and clear that this is a really important issue to the ACOs, that they have been touting as an important success factor in all of their own milestones of moving towards that, those targets that they put in place. The Secretary announced last year they're going to move to, 50%, 80% in value-based models over the next couple of years. And the vast majority of accountable care organizations are not going to be in a position to take downside risk, and in fact, many may just exit the program. So, we are still hopeful that CMS and Congress will take that into account and take into account the substantial investments that have been made to get these things stood up and the length of time that it takes to really start to get traction in generating shared savings and getting to the point of feeling comfortable taking downside risk. And particularly the size of the downside risk that's required, the magnitude is really not manageable. I mean, we've got like $1.4 billion total cost of care for our Medicare population this year. And so even just to take a 5% cap of downside risk is just an unmanageably large sum of money. So the implications of not qualifying for the 5% bonus under MACRA are disappointing, but the silver lining in the proposed rules is that if we did fall under MIPS, which is the alternative arm of MACRA, there are still advantages to being in an ACO and being what I call a non-advanced APM, in that a lot of the reporting burden is taken off the practices. There's some auto credit given around, for example, the practice improvement initiatives, the efficiency metrics, and that's weighted as 0 for an APM because so there is recognition given to providers that are in an APM even under MIPS. And we know that particularly for smaller practices, CMS knows this too in their own regs, that small practices are going to fail under MIPS. So being part of an ACO gives them the power of numbers and the infrastructure to succeed under MIPS. So I know we're just about out of time, and I think we'll stop there. And thank you for your attention and all your great questions. And I'll turn it back over to our moderator.
Thank you. We would like to take this opportunity to thank our speakers and session participants for joining us today. We will be sending a follow-up feedback form at the conclusion of this event and would love to receive any feedback you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.